So my name's Jeff Miller. I'm the Executive Vice President and General Manager for Clinical Network Services here at Scripps. And I want to thank you all for taking the time to join us and participate in this panel. And I do mean participate, because we're going to make this as interactive as we can as we go forward. The discussion today is going to focus a lot around where we are in the terms of health information networking. It's a very popular topic in the industry. And we're going to try to drive out some of the issues that we're all dealing with and things we may want to focus on as we move forward and make progress in the industry. But to start with, I'm going to allow the panelists to introduce themselves, and then we'll drop into the first question. Shahid?
Great, thank you. I hope you guys can hear me. My name is Shahid Shah. I run a blog called healthcareguy.com, and most of my experience in the last 20 years has been building electronic health record solutions or information networks. Many of the things you're probably blaming people about, I could take some blame for, so that's how you can know me.
Okay, so I'm Brian Ahier, and I also have a blog. It's at ahier.net, and I'm on Twitter at ahier. And I also am on the board. I'm on a lot of different boards and committees and work groups. One of the more important ones right now, I think, the work I'm doing with Direct Trust, and we'll talk a little bit about Direct Trust later on.
I'm Matthew Holt. So I do two things. I have a blog which I rarely write on, but several people here do write on, including Adrian Gropper and David Kibbe and Brian occasionally and Shahid, called the Healthcare Blog, which is the benefit of being the oldest blog, which is why it's doing quite well. But I also run the Health 2.0 conference, the market research group, and we also run innovation challenges. And I have the distinct pleasure of knowing the least about interoperability and all those standards of anyone on the panel, so I'll be the person talking from the lay point of view because I don't know enough to be an expert.
I'm Cris. I'm CIO for Mayo Clinic. Used to be at Scripps. I'm here to parrot things that the smarter people here in the audience have taught me over the last 4 or 5 years, and I do not, nor have I ever had a blog.
So we're going to start with a real simple question. Health information exchange, health information networking, popular topic for the last 2, 3, 4 years. If you had to give the industry a grade on how well we've done in terms of adopting and making a real value statement to the providers and the payers and the participants in the healthcare economy, what's the grade?
I would give the industry an incomplete, maybe a D- if I was harsh. I mean, we're not moving electronic data in any volume today. It happens in some cases between vendors. It happens for some channels. Scripps has been a tremendous success in e-prescribing data. But if you look at clinical data and lab data, it's not in motion yet. I think 2014, end of 2014, beginning of 2015 will be when that finally happens.
Okay.
So most of my American experience is at Stanford, where everybody gets an A for everything. So we're at a C plus, I think, because we were at an E for a long time. A lot of conversations. I'm a little concerned about because Cris is right. We are getting some what I call data utility layers going, which are a lot of the non-healthcare specific data is starting to get into platforms, even like the Runkeepers and Healthforce and others like that, and even Withings, Scales, and are now exchanging data with Fitbit. So you're starting to see the data move around. You have Qualcomm with Harvey Circles, and in prescribing, right, Scripps has done a great job. So not bad. I'm a little bit concerned that we still have at least 3 or 4 major systems that I don't understand, which means I guess only 3 or 4 people understand them, including the regional HIEs, which were funded mostly by public money, which is going to run out. What's going to happen to that? We have our 2 new behemoth alliances, which I don't understand, and Adrian will tell us don't do great stuff anyway. Adrian Gropper in the front row will tell us don't do great stuff anyway, but Commonwealth and Healthy Way, and it's the new thing called, Rob, help, what's the new thing called? Carry quality, right? Then we have Direct, which I think is email, but I don't quite understand, and who gets to email whom. And then I have the blue button on my shirt, and a group of us have been saying that's a great idea to get your data. I am the father of a happy patient of a Sutter clinic, a pediatric clinic, and I would love to be able to download the data that I can view, and I can't yet. And it's the end of 2014, and that ain't good enough. So C+, I hope we're going to be getting better. We ought to be.
Right.
I would agree with the incomplete mark, but I think we're at the cusp right now some true interoperability starting to take place. There are signs. There's a lot of good signs. You mentioned direct, direct trust, and the accreditation program through ENAC has a trust bundle that now has 17, and there'll be 20 shortly. There's others in the pipeline that are in the trust bundle, and so interoperability is beginning to happen. And then, of course, you mentioned Commonwealth a year ago, and now care quality this year at HIMSS. The big, I'm starting to get a little jaded on the big announcements at HIMSS, and then I want to see things happening out in the real world. And so I agree that the 2014, the end of 2014 going into 2015, I'm a little nervous that people aren't going to be up to the challenge of meeting the policy implications of view online, download, and transmit for the transitions of care for stage 2 meaningful use. Those two components of both patient engagement and HIE are going to be difficult for the providers and the vendors to team together to meet. So I think there's a good policy framework in place to push interoperability. There's a lot of smart people working on good technology solutions right now, and hopefully we're going to see that. So I can't really I would have to give a lower grade. I'm a hard grader. I'm not you C+ guys. You got to do pretty good to get a B, right? I'll be generous and give an incomplete.
So since I'm an engineer, I'm going to give you a very complicated answer to what was actually a pretty simple question. I see things, if you look at it from a marketing perspective, we're finally at a point where pretty much everyone is talking about it, which means now there's a chance, there's a light at the end of the tunnel that we can all see that we're all driving towards. So for the marketing, communications, et cetera, I'd probably give us a B+, A-. The only way I would improve that is if we started talking a little bit more about specifications and what it means to be interoperable, rather than let's just say be interoperable or have a good network. Now, the second piece of actual data flowing in between events where patient safety and improvement of care would happen, that's a miserable F. So when you look beyond a particular organization and you say, I need to connect between organizations or do some serious things which will help either enhance patient safety or improve patient care, we're in generally a poor condition there. Then there's the issue of two critical areas, which are the basic standards and protocols and the associated specifications that engineers need to begin their job. We're actually in much, much better shape than we have ever been. So there I would say we've got about probably a C+, B-, maybe even go to a B, because as an engineer, I can actually now go say, all right, MU requires something, Mayo Clinic has specified something, I can go pick something and engineer off of it. Now then there's a fourth part, which is, do we actually have the software and the engineering tools, the components, et cetera, ready? There we're probably at about a B also. So if you look at all four of these, reality is that where it matters for a patient most, we are failing. But the good news, and I think just like you've heard the panel say, is whether it's end of 2014 or end of 2015, we won't know that. But I think given where Cris is sitting, if he sees and says it's coming by the end of 2014, I buy that because he's got a lot of data going back and forth within Mayo and outside. I'm looking more at cross-vendor type of connectivity, which is not happening yet, alliances and other stuff notwithstanding. Reality is, number of direct messages still being sent today is dismally low, potentially a failure. Number of actual transmissions of connections between providers of different sorts is still pretty low. So with that, from that respect, you have to say that we're not doing well. The good news, though, is that the specs that we need and the engineering tools that we need are in place, which means that buyers can start demanding it without sounding crazy. That's the whole thing. So if we can see buyers starting to demand it, if us standing here can say, yes, it's possible to do, and Cris as a buyer says, yes, I'm not buying your stuff until it is interoperable, that's when I think we'll see the tide turning. Until demand exceeds the supply, which is really where we're looking at, that's where I think will be problematic.
Okay, so all in all, not a very good grade. My child came home with that report card, be a lot of long discussions, right? So now the question is, discussions aside, what is it? What are the one or two things that the industry needs to do in the next 12 months so that we're not sitting here having a conversation about the potential of networking and interoperability being good, but we're having a conversation about how we went from an F to a C or a B, and we have real results that we can value in that.
I think we're doing some of the things now that we need to finish in the next year, so that next year at HIMSS we're talking about a completely different environment. And I think that we're seeing pockets of greatness, right, where a whole lot of different hospital systems are talking to each other in Ohio, for instance. There's lots of places around the country, and there's a lot of vendors like you guys and others who are allowing interoperability to take place. I get to see sometimes the stories of people where care was improved because of interoperability, and because of, even though there may not be the scale yet of exchanges taking place, there are exchanges taking place, and sometimes those can greatly enhance the care, and that's the goal, right? So I don't know if we're going to talk about meaningful use at all. I think it's really important that people realize that the extension of stage 2 meaningful use was a delay in the beginning of stage 3. It has no impact on what you need to do in 2014 yet. And my hope is that they're going to allow some flexibility this year for stage 2 meaningful use too, because otherwise we could wind up with a sort of digital divide, right? And I know that there's others that would say, hold their feet to the fire and make them do it. And that's fine for the health systems and the large organizations that have the wherewithal to do that. But as I go around in rural communities, critical access hospitals, small physician clinics that don't have the resources to do this, I think the people that we need to hold their feet to the fire are not necessarily those rural providers and critical access hospitals and underserved areas where they're struggling, but the people that are here in this exhibit hall and the vendors. They're the ones whose feet need to be held to the fire.
So I'm torn. I think there's a communications problem still. I mean, there are too many different ways of exchanging data, and no one quite understands which ones are going to be the dominant ones. And I go back to, we have system-centric, we have email-centric, and now we have Blue Button. I hold a lot of hope for Blue Button because I hold a lot of hope for consumers, and I represent if I represent anybody, it's a group of innovators who want to build stuff off and are aching to get at that data, and would like the big systems and the other smaller systems to be able to make that data more easily available. Whether it can be done with the current technology, whether we have to wait for the world to go to cloud technology across the board, I don't know. But it seems to me that Blue Button initiative is a very, very important one, and ONC has aggressively pushed it. And I'm not as radical as, say, Adrian's in the front row here about people owning their own data at all times and having permission over it, but I would certainly like access to it to be the key piece. And I certainly am a little bit concerned that, and you guys will correct me and David will correct me, that direct is going to be between doctor to doctor and not really get the patient involved in a way that's easy for the patient and the consumer to be involved. Because to me, the really big gap, I've looked at healthcare systems across the world for a long time. Everybody has a big gap between the patient and the primary care doc, and between the primary care doc and secondary or tertiary care. Those gaps are still there, and they're going to take a while to fix. If you can at least get the patient and their caregiver as much data as possible, then we've got a hope of actually doing some good more quickly. So that's why I'm optimistic about Blue Button.
I think that's the next wave to occur. Let's make sure we nail this as far as provider to provider and being able to have the right information in the right place for the right caregiver. But I agree with you completely. In terms of access, I think that we've got with the HIPAA omnibus rule really expanding or clarifying the patient's right to access their own data. And the technology is not the hard part here. And I think as we see more and more alternative payment models coming into play, where having an engaged and empowered patient is going to be key to the success of the healthcare organizations, we're going to see more of that occur.
So I think there's maybe two buckets in which to answer that question. I think the first one is the idea of make the right thing to do the simple thing to do. So the number one thing would be to get messaging in front of the doctors in the middle of their workflow, period. If it isn't there, it ain't going to happen. If incoming messages aren't visible to a clinician in a way that they want to see them, and if there isn't a way for them to initiate communication the way they want to, it isn't going to happen. So that falls fundamentally to the vendors of EHR systems and those who serve them, which is the networks that connect directly to them. I think some of the things that ONC is trying to do around proposed regulation around the 2015 interim voluntary edition and the Meaningful Use 3 is to begin to separate out transport from content, potentially helps in that area. It might make it more confusing, we'll see. But if it doesn't happen in the systems that are being provided by the vendors for meaningful use stage 2, we're not going to see the takeoff we expect. Now, I'm optimistic about it. We run on both GE Centricity Enterprise and Cerner, and it looks like there's reasonable methods in which that will be embedded within the clinician workflow. The second sort of bucket, it falls under a slogan just as snappy as the first, which is think big, start small, move fast. And by that, I mean there's been a lot of grand dreams around full semantic, two-way, introspective messaging. What other buzzwords can I add to it? And we haven't gotten even close to that. So I'm a big fan in and believer in direct. Mayo became a member of directtrust.org. SureScripts will be part of our communications channel from our GE platform. I think simple messaging is a great place to start. Then what's the move fast bit? It is to go through enough iterations and variation that we can work out the bugs, like how many direct addresses are each of my doctors going to have? How do I resolve those so they can get to the right place? How do we deal with patient identity issues in a real simple way? All those problems need to be worked out, and they need to be worked out in very rapid iteration, otherwise we'll stall and stop. Now, Mayo is also part of an organization called the Care Connectivity Consortium, which is a group of other major medical systems, Kaiser Permanente, Group Health, Geisinger, Intermountain Health, and we just added OCHIN to the list. And we're doing a lot of advanced work around patient location and around a full two-way communication, push and pull, full connect kind of work. We'll continue to do that. It's really, really important. And it's helping us today when we trade patients back and forth between Mayo and the Kaiser system. But for us, the issue is when a patient wants to come to a place like Mayo Clinic, when we get patients from 150 countries in all 50 states every year, it needs to be incredibly easy, to get back to the comments made earlier, that a primary care physician needs to be able to send a referral to Mayo. We need to receive that patient with full fidelity. We need to treat them and return the record back to their location of care. So I think it's actually pretty simple. Get the EHR vendors to do it right, focus on direct, figure out how that evolves over time, and away we go. I'd make one last comment about patient engagement. I think for those patients who want to be engaged in their care, we absolutely need to enable it, and direct and Blue Button are great ways to do that. But I would observe that I think the species Homo medicus is an elusive and slowly evolving species. And we'll see what happens over time as it becomes easier and easier for them. But I think a lot of times people are going to say, I don't want to manage my medical records. I want someone else to do it for me. And when something bad happens to me, then I really want it to be in place. And that's what we all need to, I think, be putting in place as a precursor.
My thinking is that until we get to a point where the demand side from the provider community or health systems, et cetera, pushes the vendors to the direction where they know they have to go. There's nobody here that's going to disagree with the fact that interoperability is both good and important, and that we depend on them for making those things happen. The problem is that we don't put our money where our mouth is. So if we can see within the next 12, 18, 24 months that those of us who buy systems, whether it's large health systems or small physician practices, buy only those systems that act in the way that we want them to act, I don't think a lot is going to change. So the vendors have been trying to drive this in multiple ways. Vendors will push things in the directions that are best for them, as we understand that they will, and there's nothing that I can blame them for someone doing what's in their best financial interest. But at the same time, no single vendor is responsible for patient safety or patient outcomes, which means having a vendor responsible for interoperability will be tough. But if you start to say, and I do a little bit of work with government as well, what we find in the government is whatever I put into my RFP gets procured. So if it's not in your RFP that says you must do this, and just a request for proposal or your procurement documents, et cetera, so what I'd like to figure out is how do we educate the buyers to ask for the right things? Because if the buyers are willing to put money into a particular direction, vendors will absolutely jump over huge walls to make that happen. But until they do, it's kind of weird for us to say that we want the vendors to do, quote, the right thing, when we haven't actually put the right thing into an RFP, into a procurement document, or made the specific request. So what I'm seeing, though, the good news is that we're seeing that, especially the larger health systems, as they normally do, are starting to drive that demand. So if we go back to simple economics and say the supply of interoperable systems is directly related to the demand through actual cash payments, if that statement is true, and I think that it is, that's why we are where we are today. So if we want to see things change, we have to change them in the buying community. If you change them in the buying community, the vendors absolutely will react. We do not, for example, throw out any vendors that don't do what we say in the world of interoperability. And if we're not willing to throw vendors out, and I'm not saying it's trivial, so I'm not being naive as to it's easy to throw out a major EHR purchase that you made over 5 years, et cetera. But until we do, let's not wonder why we are in the state that we are. So if we can get together and these kind of consortiums that are created, that are focusing on the buy side of the equation, will be very helpful and they will work. Alliances, et cetera, that are focused on the supply side will continue to create new technology, but it's not actually going to change the equation over the next few years. So that's what I would love to see as a change agent, would be help the buyers buy better. And by better, that means that they've figured out where patient safety and outcomes matter through interoperability, and then they'll drive the simplicity, they'll drive the kinds of things that they're looking for.
I'm confused about why a buyer. There are three things going on. One is that buyers are buying large-scale enterprise IT implementations, which take a long time, and the two most successful companies in this business, one for the medium-sized and small hospitals, one for the big hospitals, basically tell the buyer what to buy. We all know who I'm talking about, and John Lamkin may say, I've built this beautiful system which does everything my clinicians want, and Judy and the other guys from Boston say what they say, right? So I don't get how you change that quickly. Number two, the buyers themselves, okay, eventually they're going to be paid in a different way, but Mark Berkeley, and he showed the chart this morning, we're still at 90% fee-for-service, fill the bed. So where is the demand going to come from to change the buyers without some form of aggressive change in regulation? Now it's going to come eventually, it's going to happen in different places, but 18 to 24 months, if we're relying on those two things to happen, it's not going to happen. We have to push that some other way. And I'm still struggling to see what it is unless you can aggressively push meaningful use, which is why I have more optimism for that than a big system-wide change.
I would say if you want to think about policy levers and take a deeper regulatory approach to this, take a look at what the bipartisan efforts that are underway now tied along with the SGR fix, where they're talking about taking meaningful use and PQRS and alternative payment models and the value-based payment system, all these different CMS programs, and putting them into what's called MIPS. It's Merit Incentive Program. And I think that having everything under one house like that, it makes a lot more sense and will be much more effective at using that as a policy vehicle for driving change. The last thing we need in healthcare is more acronyms, more alliances, more consortiums, more initiatives that are driven on the supply side, because then we're talking to each other in an echo chamber.
That hasn't passed yet. That's way away, and we do have VDT, which is in MU2, and we've got to make sure it's enforced.
Will high deductible health plans be the driver, the market driver that you are all looking for?
I think ultimately the answer is yes. Whether it's 18 months or 24 months. I mean, I was just talking interestingly to a private equity firm last night. They're investing hundreds of millions of dollars, and I asked them, well, what was your central investment thesis? That was it, right? He said, why are we looking at trying to invest more in health IT today, and where should we invest it? It's on the back end. It's the data collectors. It is the information exchanges. Why? Because, and remember that in case you haven't followed all the dots, a high deductible insurance plan primarily means that you are now responsible for potentially $8 to $10 to $15,000. My deductibles per year are I think $12,000 or something like that. So I'm responsible for $12,000 of health spend every year. Presumably I'm going to do a better job managing that than if it was only $2,000. So the higher the deductible, the more likely that the consumer drives the decisions. Now, so we're going to see that. I think that the consumer will start to drive more decisions, but the question is, will the provider community, the health systems, et cetera, that are in place today, be ready to react to those demands of consumers? So I'd say yes, the answer is it's going to get there, but it's several years away, probably principally because of what Matthew was saying, which is, are they ready? And I think if we look at the buy side being influenced by the consumers, potentially there's a nice little perfect storm on its way.
And that's a great question, by the way. And I think that one way of looking at it is, in a physician office, right now, a provider sees you walking out the door as a patient, and they say, you know, whether they collect the $10 from you now or not, that's $10 walking out the door. When that's $100 walking out the door, I'm much more interested in following up with you and making sure that you're cared for. So I think that it is going to be a big driver. When I say maybe, I'm starting to look at this 18-month to 2-year horizon as something where we really need to accomplish a lot. And I don't know if that's going to push us fast enough to get us where we need to go.
I think it's a really interesting question. I think this is the case that we're about to have a bunch of shifts in the market, and I don't know which way they're going to go. So a couple of them. One will be, if we have enough high deductible plans, majority of people do not use healthcare above their deductible limit, which means they will not hit their insurance benefit, period. And they'll be paying for everything out of pocket. Okay, well, what will the insurers do to be relevant in a world like that? Well, they're going to try and steer patients to high quality, high outcome providers as a way of providing value to the employers who pay them or the consumers who buy the plan directly. Why should I sign up for Blue Cross Blue Shield of your state plan if you just give me the same old network that everybody else does and I don't have a discounted price with that provider and so on and so forth? So I don't think you can talk about high deductible plans without thinking about how does that game out. And I think it games out in terms of, do networks narrow? Are provisions on providers become different and more specialized and so on? So, you know, I think that's a big deal. We'll see how it comes up. I'm not exactly, you know, a lot of people are a lot smarter about this than I am. And I'm not sure I see anybody around who's got a magic bullet on this one. But for sure it will change things.
I'm going to move away from the consumer for a second and want to come back to a thread that started earlier in the discussion. We have a multiplicity of standards to move information around today. Is that multiplicity of technologies harmful to our goals in the next 12 months, or is it in fact useful in terms of giving users choice in how they move information around?
As a member of the Health IT Standards Committee, I think we probably made a mistake in allowing optionality, because or means and for the vendors and therefore for the providers to a large degree. It would have been better if we had found one standard and stuck with it. Exchange, IHE was too heavyweight, so direct was invented. There is still a need to do the things that will be required by the higher weight standards at some point in the future, and direct will not be sufficient forever and ever, amen. But it would have been better if we had started with something simpler. I think that providers and vendors are going to look to the networks like Scripps to figure that stuff out.
Okay.
And to become the gauge shifter and interoperability provider between what would otherwise be impedance problems of mismatched networks. I don't see any option. The facts lay as they are now, and we have to deal with multiple standards.
Yes, I'd only say that this is as much a marketing problem as it is a standards problem. You have to market to everybody in the system, including all the providers, because no one can understand what this stuff is. I mean, you know, once you get out of the concentric circle that goes past here, and if you did the poll of the whole room, the whole hall, you'd be hard-pressed to define what these things are. And it's just very tough. And once you get that into a marketing problem, we need something really simple. TCP, email, people get it, they understand it.
Right.
I think now people get WhatsApp.
Right.
Or somebody must have got it because there are 450 million users. We have to get to that level of marketing simplicity, which means the vendors have to work on it, with people like you.
You know, I like the way you brought up the sort of the evolution of the internet itself and the way standards evolved from that. And so I think that having some optionality is good, some optionality, but you have, you know, to standards imply that there's a standard and that this is the way to do it. Having 73 standards to do one thing is like having no standards at all.
I tend to think that even though, and since I'm talking from the builder side, because we build a lot of these things, is the and isn't so much a problem in the optionality side, so long as it's pretty clear what the use cases are, in which conditions those options will be used. So if you said, for example, that both direct and exchange are required, I'm a technician, I can throw software together, no problem. What I can't figure out is which button, when pressed on my EHR, sends it via direct versus sends it via the exchange, which I think is what Cris is alluding to, is that it's that confusion that is caused by the workflow. But I think that based on where we are, especially the NIST-related MU standards have been around for so long, there's really, aside from direct itself, which is now about 5 years old, there's really not anything new. So technically speaking, we can do it. Where we do need some more direction, though, is use cases and workflow-based direction. And that, again, I don't want to try to blame the buyer community. I mean, we need to figure out together. This is where the vendors need to work together with the buyers and say, at what point does it make sense to do direct versus anything else? The more of the optionality problem probably isn't there. It's the fact that HL7 and related CCD and CCR and the C32s, those, I think, when you put all of those together, not having a particular direction in the file format as opposed to the exchange format probably is a challenge. But I think in the end, most of the engineers will be able to figure that out because there's going to be 2 or 3 or 4 networks. Within the next 10 years, there's going to be 1 or 2 or 3 SureScripts-like systems that are going to be the centerpiece of what we do, just like today. I mean, if you think about it, in 2005, if somebody said most scripts would go through one network, we would have looked at it and said, well, that's just not possible. But I'm sure you guys will say, of course it's possible, because that's what you're doing today. So 5 years from now, 10 years from now, it'll be a very small community. But I think for those of us that are builders in the room, just like Cris said, it's a reality. We can't think of it as an or. These are all ands. But my suggestion is figure out from the use cases perspective, which of the ands focus on which particular areas of standards, and things will go nice and smoothly for you. If you don't, and leave it up to the users now to even decide what their options are upon your options, then I think we're going to have a lot of problems.
So you introduced a very new topic, but a very relevant one. We've been talking about multiplicity of technologies, but it was a transmission multiplicity, IHE, direct, blue button, right? Although blue button plays in the format side as well. The whole data issue. I mean, is it the network that's the issue, or is the real issue in adoption the fact that even if I move the message, I don't know what the message means when I get there? I know I had, in my previous life, ran a state HIE, and we worked with one vendor, and we got a CCD, and gender was represented 3 different ways in the same vendor's CCDs, right? And just a simple field like gender is represented 3 different ways. How do we ever make sense of what we have?
50 of them on Facebook now.
What? Yeah, it's 50 of them
50 on Facebook, so you know,
right.
3 was nothing.
So is it the network, or is it the data, or is it both?
So I'm not as pithy as Cris, but I'll throw one in that says data that is not used is useless data. And the reason why we have these problems right now is because not enough of us can send data from one party to the next, and so we don't resolve these issues. And this happens so in general, in the non-healthcare world, we deal with networks as what are called value-added networks. So an HIE is nothing more than a VAN in every other network. So the VANs in the 70s and 80s, between Walmart and its suppliers, between airlines and their suppliers, was just as useless as VANs are today because the data was not used. But now, think about when a purchase is made on the internet, when a supplier has to know from the time when the button is pressed on the purchase of the thing on the internet, all the way through the supply chain, that data, every piece of data is now crucial. which means over time that data got corrected. So yes, it is all about the data. I mean, there's a simple answer to that, but the slight nuance is that until we start using data that someone else sends to us. For example, if a doctor sends a fax from one doctor to the next, and the other doctor never looks at the fax, do we blame the fax machine? Do we blame the piece of paper that the writing was done on? No, we say, hey doc, read the freaking fax. That's what we say to them. But here, what we're saying basically is that I'm going to send you data which you're never going to read because there's no way to import it. Even if there is a way to import it, it doesn't get to the right fields, so you don't depend on it, you don't trust it. And so I think that there is a chicken and the egg problem here, is that even if we had everything perfectly laid out, if there's nobody on the other end using the data, not receiving it, using the data, I think we're going to have some trouble.
I think we've actually done a fairly good job of developing content standards. It's very complicated, and of course it's not perfect, and there's a lot of times where they don't match and where you have too many options in a field and they don't match on the other side. But I don't want to let the perfect be the enemy of the good either, because you brought up, how are we doing this now? Most health information is transmitted by fax machine, the same way we did it 20 years ago. And so if what you're doing now, if this is an improvement, even though the content standards and the interoperability may not be perfect and be exactly what we want, is it better than, are we making improvements? And incrementally, I think we're starting to see some improvements.
So I think the data is the symptom and not the disease. Okay. The fact that the data is not perfect is an indication that the network isn't functioning well. So the CCR was a better spec than the CCD, period. Yep. It had better represented data. For a bunch of sort of political industry reasons, it didn't become the standard, so what? I think CCDA kind of fixed it. But if we had functioning networks, the data would get better and better, and it would get better a lot faster. I mean, you look at a bunch of complicated standards in the internet, and they've figured out content pretty well. That said, I'm pretty intrigued by, what's next. I don't necessarily think we're going to land on Exchange. If Exchange was the answer, it would have been the answer 3 years ago, and it isn't. I don't think we're going to land on Direct. It's insufficient to just push. There's going to be something next. Who knows what it's going to be? I mean, a lot of us are pretty excited about Fire. We think it's pretty interesting. It's got some combination of content and transport. It's being thought up, by some really, really smart people who are developing it iteratively and carefully. But I think that the thing to watch is when the data gets better, that's a sign that transactions are actually happening, would be my shortcut on it.
Okay.
Chris, you may not be real active on Twitter, but the things you say are very tweetable.
I was going to say, everything's in this nice 132
and if it's in 140, you should.
Yeah.
You really.
For you, baby.
I appreciate that. I hope you're all tweeting out there.
That's right.
Hashtag just for you, baby.
Baby, there you go. Got to get the hashtag part in there. Surprisingly, I didn't hear one of the issues that I would have expected to hear, and it's the issue of patient consent, right? We have a very mixed model, and that's probably being polite, as it relates to consent and who can use what information and who's allowed to send what information and who within an organization can actually see that information. Consent an issue, or will it be an issue, or will it go away?
Well, no, it is an issue. It's absolutely an issue, especially when you start thinking about the granularity of consent that's available to consumers and patients now. I think back to the PCAST report and looking at the way that the atomization of data, or the molecularization at least, of the health data, and these data were supposed to be tagged, and e-consent, is a big deal right now. The problem also is there's no national model for consent, so you've got 57 states and territories that are each approaching it from different ways. And you've got sort of these spaghetti strands of consent models out there. And so it's a big problem.
We actually were emailing back and forth the other day, and this was about WhatsApp. We're back to the $19 billion that none of us made. But here's the issue, right? So the story that Adrian emailed me the other day was that WhatsApp, as soon as it got bought by Facebook, lost 300,000 members in Germany, because the Germans are obsessed with privacy for various historical reasons that you might be aware of. And I was saying to him, it's great. If I am, texting my kid, my mistress, my, partner in crime or whatever, I'm not sure I want anyone to ever see that. But if I am, each person, Peter, part of health data, there are some parts I don't want anyone to see ever, and there are a series of other parts that I want different people to see under different circumstances. And if I'm dying on the street, I want everyone who's in that whole chain automatically to get the data very easily. But other parts I want to have encrypted, I don't want my employer to see. And you understand that it's a very complex piece. And I don't think we have worked through societally what that even begins to mean. And if you want an example of where it's going wrong, in the UK this week, they've been having the issue where they were basically going to take all the anonymized, depersonalized NHS data and stick it over for research purposes, which I think is a great idea. I would love to see more better medical research on real data rather than the crappy clinical trials we have now that generate much of our healthcare. And there's been a sort of revolt, and our buddy Tim Kelsey over there is in trouble because he's been attacked by the non-consent crowd. So Adrian may have some different views about this than me, and others may have different views, but we have to acknowledge that there are different types of consent and use for the same piece of data, which vary dramatically. And I don't know if we're even close to thinking through that stuff. But
Actually, I'm going to give a shameless plug on the issue of consent because it is a big issue. It's one of the things that the Care Connectivity Consortium that I mentioned earlier, Kaiser, Mayo, Geisinger, Group Health, Intermountain, have been working on is consent management across context. And we didn't use very complicated technology, but it's intended to put in front of a clinician in real time, do you have consent to receive information about this patient? And if not, means to ask the patient right now, may I get your record from Kaiser Permanente, yes or no? To be able to receive that, transmit it to Kaiser, for Kaiser to say, yes, we want to share that with you, and in comes the data. So shameless plug number one is we're working on it. Shameless plug number two, I'm talking about it tomorrow morning at 8:30 in some room, God knows where, with Eric Heflin, who's the Chief Technology Officer for Healthy Way. And it's really interesting stuff. It was primarily done by Intermountain and some others. And it's really impressive work. And I think it's a model that part of what we're trying to do with Care Connectivity Consortium is sort of give stuff away. And this is a model we kind of want to give away in the interest of sort of the public weal.
I'll just add a shameless plug for patient privacy rights. There's a summit in June this year, so we'll talk more about this over there. But I tend to think that the privacy part, I do agree that society hasn't decided as a whole, but segments of society absolutely have decided. For example, there are companies, and you just saw a few mentioned here, where they do care about privacy, and they've adjusted their processes and their procedures, et cetera, irrespective of technology. So it's a process, it's a people problem, and of course technology will come as it will in all cases. What I believe that the rest of the community, most patients, absolutely don't care about privacy, because if they did, they'd do something about it. That's one thing. Second thing, we want them to do more about it, but we in the vendor community on the builder side are just doing a horrible job caring enough to do the minor extra cost it takes to do security and privacy. And number three, we're kind of depending on the hope and the prayer that there are enough people who will do the right thing that it will fix itself. None of that, of course, is true. So if you look at the first part, it goes back again. Privacy is the same as interoperability. It's a question about demand. If I'm a patient at Dr. X, and Dr. X happens to work at Mayo, and I saw that Mayo did not do a good job with my privacy, and then I go to Brian's hospital because I said, I didn't like the way you chose to release my information, et cetera, so I'm going to switch hospitals. That's what it means to truly care about privacy. And there are some people, a small group of people, that will do that. Unfortunately, the larger group of people, just like they don't care about taking care of their own quantified self or homo medicus, which was awesome, because we don't see homo medicus, we don't see homo privacy either. I don't know in this particular case that we're going to find it. So if you go back to supply and demand, the supply of interoperability comes when people are going to demand it. The supply of privacy-focused systems will come, but we on the patient side have to be able to say, I'm willing to leave someone who's not going to take care of my data. And that's really that's really where I see some of the problem occurring.
With respect to the consent issue, that is playing out right now on a very big stage in the form of patient matching. And you don't have to wait for FHIR or for anything that's going to happen 12 to 18 months from now that we were talking to before. If the patient matching work that's happening right now, because it is on the front burner for almost everybody, decides to adopt what patient privacy rights call fair information practice, which we didn't invent. That's been around as part of the patient matching initiative, then you will see the consent thing work its way through. But right now, there's only one place that I'm aware of that has decided to do that, and that's in the NSTIC IDESG process. And that is a slow-moving train. So if there is anybody in the industry, and especially SureScripts, that is so interested in dealing with patient matching at the next level and interoperability, then I would just pay attention to that one thing, namely fair information practice and patient matching, and consent will fall out of it.
All I'm saying is consent means different things at different times, and it's a complex piece. And you can do the over. There's an old science fiction story about where you had to vote on every single decision ever, and the final vote was, and a computer would spit out the votes. And the final vote was, would you vote for a dictator so you can stop voting? And we're in danger in the consent world of having to consent to absolutely everything. And you want these. It needs to fall out and be automatic, but be sensible, right? So I don't know. I don't know less about this than Adrian, so I'd like to see how it plays out. But anyway, but I would love to go back to direct and explain when I hear from David why I'm wrong. Can we do that?
So the issue is that you're very skeptical about direct being available to patients.
I'm skeptical that it will be, doctor to doctor, that they won't tell patients about it, that patients, that it'll be too hard to get an email address, that the patient will have to get an email address which has to link to something that actually takes the data, and it just be too much like hot.
I want to reassure you that this is really almost a done deal. It's a last mile problem. It's as though every patient in the country has the direct trust cable, the direct exchange cable, right up to their house, but they don't have the infrastructure to utilize it yet. Okay, so it's been, for those of you who don't know, Direct Trust is an industry alliance of 120 organizations supporting direct exchange. So it includes the providers of direct exchange, and it provides some of the consumers like Mayo Clinic and Baylor and other medical centers. It includes almost all of the electronic health record vendors and or their HISPs who are providing services to them. So it's been a guiding principle of Direct Trust and our membership from very early on that patients and consumers should be full participants in direct sooner rather than later. Because of stage 2 meaningful use, right, and because of the demand on the provider side, we've focused primarily on provider to provider. But there are now 17 HISPs who can now begin to take and serve patients with direct addresses. And those patients and consumers who would utilize those direct addresses could be able to connect with any one of the HISPs and their thousands of subscribers. So what we need is you to know that this is available. We need a really organized campaign of education and information, and we need to support a whole new infrastructure of what I call next generation personal health records. And there are some of them around, Healthy Circles, Vitals, Health Companion.
These are members of Direct Trust.
And these are members of Direct Trust. So, but if the Health 2.0 community and the patient advocacy community still thinks this is a long way away and it isn't going to happen, it will be harder for it to happen. So I'm really looking forward to working with you and others to get the word out that we can get this done in the next year or so.
So over the last just 6 weeks or so, we put together a very tiny group of people. So again, from a builder community, just building out a direct exchange between 4 of us as vendors. We just happened to work together, so we're going to say, well, let's try this out. It was very painful, but once it got done, it worked. So the technology's there, it works fine. Just like SMTP, which is what all of our email works on, was invented in the 70s, and it took Hotmail in 1998. From the 70s to 1998, it took Hotmail to actually make mail that popular to where it became in the hundreds of millions. So up until Prodigy days, CompuServe, and I'm dating myself, I think way too fast here. But if you look at those days, they were still in the hundreds of thousands and the millions, and I think you'll see that happening today. But just like David's saying, I think that, so as a builder, and having built a HISP and signing up the direct trust, putting our chains in there, it's very technical, but it all works. So there's no question about it working. I do agree, though, that that gap of who's the Hotmail here, what's it going to be? I mean, there's an interesting company that makes a small app called Prime that is basically an HIE of one. It's a personal health exchange where you can connect to various providers with their blue button or CCR, pull them in, consolidate it into a record. Now, unknowingly, they've created a little exchange system. They also put in a direct email box for every one of these patients, and they said not a single direct message has come in, which means that the guys using the app are pressing the buttons. Was it something about the fact that direct was more difficult to do, et cetera, technically? No, it's there, it's working. Let's push it. We got to find the Hotmail, though. I think that's the key.
Sure, and I would just say that with direct, I really still think that we need to nail the provider to provider. At the same time, though, there is a lot of progress being made into provider to patient communication, as well as provider to payer and payer to patient. And so, you know, there's a lot of moving pieces, but we really need to nail this provider to provider this year and make this happen.
So let me just say one thing, which is that when Kaiser decided it was going to try and drive up the number of people who were using, basically going online, looking at their basic email to the doctor and their own record, they did a lot of campaigning. They had signs in the parking lot, they had adverts on TV, they really wrapped it in, and they got the numbers from, I think it was sort of 30 to 60, and they did a nice job, and they're not going to get to everybody, but we need that kind of campaign. So my daughter goes to basically a safety net clinic in the southeast of San Francisco, and I was very excited because finally I had an EMR that I could get access to and go and see myself. First time ever. So I got very excited. I had to go and I went and I said, so to the doctor, how do I get it? And she said, well, you know, I didn't know that we had it. And then she figured out that I did have it. And then she said, well, no one's ever asked me for it before. And I went, well, I'm probably the only person in the southeast of San Francisco, which is not a wealthy neighborhood, that actually knows that this damn thing exists and you can do it. But the Palo Alto Medical Foundation has the same system, and they have, I just saw Paul Tang, they have 88% of their members on it because they marketed it to the right population, and frankly it was felt that, you know, the southeast of San Francisco didn't need it. So we need that marketing campaign. Along with that marketing campaign, the other part, which is kind of budding and waiting to get there, is the group of care navigators who are going to use Healthy Circles or whatever, who are going to actually run this for the, if you go back to what Mark Berkeley said this morning, for the 15% of people who are really sick. I'm not expecting an 85-year-old, you know, mother to have a 85-year-old with multiple chronic conditions to have that 16 screens up and behave that. But I do think there are people who are going to take that role for her, and that's the group. We need to sort of, this is what to come together.
Yep.
You know, I guess the one question that wasn't asked, so it's the dog that didn't bark. The question that wasn't asked is, you know, why doesn't this happen? Are providers resistant to moving data around and all that? You hear that often. And what I would say is, you know, working with clinicians, I haven't met a single clinician who didn't want to talk to their colleagues about the care of a patient, period. And yet at the same time, health systems are not connecting to each other at the pace at which you would expect. And I think a lot of that is just, it's easier to not. So, you know, I think there's a real hunger out there amongst providers to connect with each other, and I think it's going to happen as soon as the tools are available. So again, I guess it's the, you know, make the right thing to do, the easy thing to do, and the docs are flocked to this stuff. And once they do, they'll start talking to their patients, and their patients will say, you mean I can get my data? I think that a lot of that puts it in motion. So the idea of, as Brian said, start this year with provider to provider, look for the halo effect of provider to patient. I think we're going to see some great things. I think a year from now, if you have this panel again, it'll be more of a success story and less of a someday soon story.
So Doximity, I don't know how many docs do we have here? You two are it. Are you guys on Doximity? So 250,000 doctors now, I think, out of basically nothing 3 years ago with messaging in it, right? Right. So that's a good example. That is a non-health system-based physician community that you can all email. It's basically LinkedIn for doctors. If you don't know, they're going to make money selling recruiting like LinkedIn does. But eventually they built a messaging system in there, which is growing like wildfire because physicians do want to message each other about referrals and cases and what have you, right? And you know, maybe if we don't get it right, the answer is to give the whole national NHG system to Doximity and let them do it.
There you go.
They'll take it with short scripts. Who knows?
That's okay. That's
kidding,
okay.
I'm
All right, we could continue this conversation for at least another hour, right? So I think you're right, Cris. We're going to come back. We're going to bring this group back together at some point, and we'll have a conversation, and hopefully the answer isn't incomplete. I want to thank our panelists. Can we have a great round of applause for all of their insights?